Um,
Is it visible on full screen?
yes, now full screen.
So, good evening, everyone. At the outset, I, Pallavi Paul, on the behalf of Mankind Pharma, welcome all the respected doctors to this fourth series of major conference highlights. So, before we proceed further for the program, let me introduce you to Mankind Pharma. So, I'll be just giving a brief introduction of Mankind Pharma. So, if I talk about Mankind Pharma philosophy is serving life. And the three pillars of Mankind Pharma is quality, affordability, and availability. Mankind Pharma was established in 1995, which was founded by Mr. R.C. Juneja. Mankind Pharma is number one rank as per prescription audit, number three rank as per IQVIA, August 2021. Mankind Pharma revenues have strong presence across prescription drugs, OTC, and veterinary medicine. Mankind Pharma has been first time granted the worldwide patent up to 2037 for novel anti-diabetic molecule GPR119. We pay our respects with a 100 crore contribution to our doctors, nurses, pharma professionals, policemen who have sacrificed their life during this COVID pandemic. We thank you all for your continuous support and encouragement that you have given us. And we believe partnership in care. So now I would like to introduce our panelists. First of all, Dr. Amrish Mittal, who is a Padma Bhushan and BC Roy awardee, head of endocrinology and diabetes department at Max Healthcare, a group of 16 hospitals. Dr. Shashank Joshi sir, who is a Padma Shri awardee, chair International Diabetes Federation, Southeast Asia Dean, Indian College of Physicians, endocrinologist, Joshi Clinic, Leelavati Hospital. Dr. Krishna G. Shishadri sir, who is a senior consultant endocrinology and diabetes in Apollo Hospitals and senior clinical and research lead Apollo Sugar Director, Primer, a medical education company, and PMS, a not-for-profit medical organization. Dr. Sujoy Ghosh, who is professor of endocrinology at IPGME and R, Kolkata, American Association of Clinical Endocrinology, International Clinician of the Year 2021, WIDF Award for Innovation in Diabetes 2021. And now I would like to invite Dr. Rajiv Koval, who is doctor at Dr. Rajiv Koval's Diabetes Care Center in Andheri, West Mumbai, and Nanavati Super Specialty Hospital in Vilepale, West Mumbai. He's a founder, member, and secretary at United Diabetes Forum. Sir, I invite you to moderate this session and debate on the highlights which were presented in a recent conference.
Thank you so much, Pallavi. Thank you, Mankind. Thank you, IJCP, for facilitating this. More than moderating, I end up learning a lot from these four veterans who are here today. Thank you all for joining us today. So we had the International Diabetes Federation's annual or it's by once in 2 years scientific session, which just concluded around a week back. And a lot of takeaways from that session. And we would have 4 top metabolic physicians and endocrinologists of India from 4 parts of the country who would discuss that. And let's hope that we add to your clinical armamentarium and we make you richer in the next 45 minutes as such. So let me start from the north, and then I would go clockwise. Dr. Amrish Mittal, I'm sure nobody needs any introduction to him. So, sir, heart failure, there's a lot of talk about heart failure. And if you ask a common doctor, he says, I don't see much of it. Where is heart failure? But when you look at data, event rates are 8 to 10%, almost twice that of atherosclerotic cardiovascular disease. So are we missing them? What are the risks for heart failure in patients with type 1 and type 2? Is there any differences in them? Some of them were discussed at the IDF. So your thoughts on it, please, sir?
Thank you, Rajiv. It's good to be back amongst friends and colleagues. And yes, of course, heart failure and diabetes clearly is a new baby. Okay, it's still new because, I think if you spoke more than, say, 10 years ago, very few people would be discussing heart failure and diabetes. It was confined to like one paragraph or something, in a discussion or a review article. It's only interestingly, like happened with I would say to some extent bisphosphonates and osteoporosis, or maybe with statins in cholesterol field, that the discovery of drugs sometimes propels us to understand more about the disease per se, because you find benefits that you weren't expecting to find. And I think the research in the area of heart failure and diabetes has been fueled by the discovery of molecules like SGLT2 inhibitors, which are actually quite remarkable in many ways. But having said that, as cardiologists got their act together, and as disbelieving endocrinologists also sort of converted, we realized that actually heart failure is a common occurrence in diabetes. When we talk of heart in diabetes, it is not just the traditional MI or angina or like coronary artery disease, as we say. It is also, and it need not be classic diabetic cardiomyopathy as described in our old textbooks. There is a whole lot of pump failure in between. That is a very major component of diabetic heart disease is actually heart failure. And so many of the outcomes, including the terminal outcomes like death, could be determined by heart failure, because when you have heart failure, your death rates increase exponentially. So rather than just getting an acute MI, so I think that's the understanding. Basically, there is a shared pathophysiology, perhaps. It's not that just diabetes is aggravating heart failure. Heart failure, is it aggravating diabetes? We don't know. But the fact is that insulin resistance as one probable oversimplification, but insulin resistance clearly is a phenomenon that contributes to both. So they sort of, in a sense, perpetuate each other. So let me say give you some figures here, and then come to the specific IDF, a remarkable talk by Professor Naveed Sattar, which was there. So the important part is that if you look at patients with heart failure, Western data show that about 40% of them have diabetes. If you go to a ward which has heart failure patients, I'm sure the figure will be higher because in India, because I remember doing this for the coronary artery bypass patients, and the figure was above 60%. This is hard data, consecutive CABG. So similarly for heart failure, roughly half of our patients with heart failure will have diabetes, right? Basically, the risk of heart failure in diabetes is increased. It's at least doubled, and some studies have shown up to fourfold, but definitely it's at least doubled. If you look at what is the proportion of people with diabetes who have heart failure, right? That is different studies. Maybe 10 to 20% is a good number. Some people give much higher figures, but 10 to 20% is a conservative figure, I think, by the American Heart Association, somewhere in that zone. But it is 4 times higher than in people without diabetes, right? So and as you go above 60, that becomes even higher, above the age of 60. So I think these are important points. And the other important point is that even mild dysglycemia, and we'll explain that further. When you talk of type 2 diabetes, of course, I'm talking largely of type 2 diabetes here. So let's not and I'll come to type 1 later. So all the facts I've mentioned are applicable to type 2 diabetes largely. But here, again, even milder dysglycemia, even in the pre-diabetic zone, when you have higher fasting glucose, higher A1Cs, even there, your heart failure risk tends to go up. So it's not a linear relationship with HbA1c, perhaps that you find in the kidney or in the eye or other organs, some other organs. I think these are important points. Let's now, well, there are other things that that diabetes does to the heart, and heart does to the diabetes, heart does to diabetes. But important to understand that in addition to conventional atherosclerotic mechanisms, there are other mechanisms at play. It is not just conventional atherosclerosis, plaque formation, and blockage. There is much more happening. There are metabolic changes. There are muscular changes. There is cardiac myocyte is affected. There is left ventricular hypertrophy in the bargain. There are a whole lot of fluid and hemodynamic changes, which perhaps I think Sujoy will discuss. But the thing is that, and that is the connection between kidney and the heart, but there are a lot of fluid electrolyte changes. So it's hemodynamic also. And, so all these things are important. And the important point again is what Dr. Sattar said that. What did he say? He summarized all this information, which I'm giving you. But he also told us that you distinguish type 1 and type 2 diabetes. And, as compared to type 2 diabetes, the risk of heart failure and type 1 diabetes may be even higher, perhaps. If you're twofold here, you may be 3 to 4-fold there. So that's one point. And it may be linked in type 1 diabetes largely to glycemic control and duration. Duration is the major determinant there, right? Whereas in type 2 diabetes, as we all know, heart disease is a result of multiple pathophysiology, some of which I pointed out, but we also know the associated hypertension, dyslipidemia, all those things are there. But the interesting fact that he brought out, which is mentioned earlier, but it was emphasized very neatly by him, is the fact that obesity or BMI or waist circumference has a more powerful relationship with heart failure than an A1C, for example. So I think that's important, that the role of BMI and obesity in this cannot be ignored. We know that obesity and type 2 diabetes are together, everything, right? But actually, perhaps more than even glycemic control, obesity plays or waist circumference or body weight plays a big role in determining risk for heart failure. For risk for heart attacks, MI, we all know that. I mean, I'm not going to go into that. I guess these are the main points he made, that in type 1 diabetes, it's duration that matters. Firstly, heart failure is common in both types of diabetes. There are multiple mechanisms by which the heart and diabetes are connected. The role of inflammation, the role of altered hemodynamics, the role of impact on cardiac muscle, all that cannot be ignored. And it is not just narrowing of the arteries and plaque formation. Now, within this, we find that people with type 2 diabetes, as I said, have several-fold higher risk, etc. But the fact is also that the linkage, even with mild dysglycemia, has been described. But in everything, it seems that the link with obesity or BMI or waist circumference is much higher, right? And in type 1 diabetes is mainly with duration of diabetes. I think I'll stop here and we can, of course, discuss as we go along. It's the fat deposits in obesity, in overweight type 2 diabetes, the bad fat, as we call it, I mean, it's proposed that maybe because in type 2 diabetes, a lot of inflammatory component from bad fat, it may be more PEF, as they call it, preserved ejection fraction heart failure, perhaps. And type 1 diabetes, more conventionally driven by duration of diabetes, maybe by ischemic heart disease, and more of the usual reduced heart failure ejection. I think reduced ejection fraction heart failure. I think I'll hand it back to you, Rajiv.
Thank you so much. That was very well summarized, sir. And important takeaway is that somehow we do not give that much of weightage to BMI when we actually treat heart failure or patients who are at risk for heart failure. And this actually raises eyebrows of everyone, that probably we should not be just targeting HbA1c, especially in type 2 diabetes. And all these risk factors are extremely important. I come to Dr. Sujoy Ghosh now. Kidney, is it an affected organ? Is there a bidirectional relationship? Is it a cause or effect? Does kidney cause heart failure or diabetes cause kidney disease? So it's a complete, and Dr. George Bakri spoke very well about this relationship. I need the Indian Bakri to talk about this confusing pathophysiology, I would say.
Right. Thank you, Rajiv. Continuing from where Dr. Mittal left off, actually, this is in continuation of what he's already mentioned about, diabetes and heart failure. And we've realized that when the FDA in 2008 talked about the 3-point MACE, they got something wrong. In that composite endpoint, they never thought of heart failure in the first place. And, the first signals that something was wrong in that endpoint came out in Fidelity trial. So if you look at Fidelity, a lot of people had hospitalization due to heart failure and heart failure related deaths. So that kind of first triggered our interest in heart failure and diabetes in a big way. And then we all started talking about the DPP-4 inhibitors and how they might actually be bad for the heart in terms of the heart failure. Well, thereafter, we had Carmelina trial. That was a group of people who had bad kidneys. And there you showed that linagliptin was safe in terms of heart failure. So that was reassuring for the DPP-4 group of drugs. Now, if you look at chronic kidney disease and heart failure, the relationship is bidirectional. And you would see that individuals who have chronic kidney disease, they seem to have more of heart failure. And individuals with heart failure seem to have more of chronic kidney disease. Now, let's just talk about, first of all, a group of people who've got bad kidneys and why do they have heart failure? If you're looking there, the easiest way to say would be, you're having bad kidneys, therefore you're volume overloaded, and therefore you're going to have heart failure. That's probably an oversimplification of things, and that's probably going to happen only in CKD stage 4 and beyond, but not before that. So what is important is, what we have understood in the past is when we've looked at kidney disease per se, we know one of the major problems is activation of the RAS, the renin-angiotensin-aldosterone system. And we've been using drugs in the past to prevent kidney disease as well as, improving heart failure outcomes. We've been using ACE inhibitors, which have been doing well. The ARBs haven't been that great when it comes to heart disease outcomes. But, if you look at valsartan, that did do well in terms of heart failure. And then we went a few steps further to try and combine ACE and ARBs, which didn't work because of hyperkalemia. We tried direct renin inhibitors like aliskiren. Again, you had a problem with the hyperkalemia. The other group of drugs that we've been using quite successfully was the aldosterone antagonists. So you first had the RAIL study and then the EPTA study, the EPLIS study. So you had spironolactone, and then you had eplerenone. Again, there you had a problem with hyperkalemia in individuals as well. So if you actually look at the pathophysiology of why both of these problems happen probably together, one of them is, of course, the underlying diabetes and the traditional pathway of all of the things that we talk about. The other two are essentially, number one, activation of RAS, and number two is inflammation. Now, Dr. Mittal was talking about how inflammation actually might be a cause of heart failure. In there, I would again break it up into two bits. One is the body fat, obesity related inflammation bit, which we all talk about, the ectopic fat and the bad fat, and the adipokine, the hepatokine, and the cytokines going off in terms of, the traditional TNF-alpha, interleukin 6, and the fetuin A pathway, the macrophage activation, and the TLR pathway, which is, quite well documented in several of the other complications of diabetes as well, not just heart failure and, kidney disease. Remember, one of the common pathophysiological end event in both of these complications is fibrosis. Now, that's essentially triggered by the inflammation, which leads to fibrosis. And even in med school, we were taught that mineralocorticoid receptor activation causes increase in fibrosis. So it's quite, logical, therefore, that mineralocorticoid receptor antagonists might, in addition to just blocking of RAS, might be actually reducing inflammation and fibrosis. The other pathway of, inflammation that we've all been talking about is essentially gut microbiome. And, there are several studies postulated about how obesity, and even here in the presentation that Dr. Bakris made, about how even renal disease can actually alter gut microbiome. And he elucidated some of the studies and pointed out, for example, there's the uremic toxins per se might actually alter the gut microbiome. There might be microbial dysbiosis. And he used a term there called pathobiontics. Pathobionts basically means that you have organisms which are there in abundance, which are associated with pathological conditions, but you really don't know whether they are pathologically causative. So pathobionts are organisms which will be there, which are associated with bad outcomes, but you really don't know the mechanisms through which it happens. And he also talked about there's being a decrease in a branch chain amino acid and decrease in short chain fatty acids. That has been proven in even animal model studies to show that these are actually important for maintaining the integrity of the gut, and the permeability of the gut might change. The absorption of endotoxins might change when you have these problems. And he went on further to look at studies to show that if you have either chronic kidney disease or heart failure or both, there might be certain biomarkers which might tell you that things are going wrong. For example, we classically talk about NT-proBNP and heart failure, but he also showed that there was a direct correlation with highly sensitive CRP, interleukin-6, and of course our good old friend microalbuminuria. Microalbuminuria is not necessarily just a marker of renal disease, but it's a marker of endothelial dysfunction and inflammation. And it's from here that he actually moved on to the newer group of drugs, or the class of drugs that we are talking about, that is the non-steroidal mineralocorticoid antagonist. Finerenone is the prototype drug. And in the last 2 years, we've heard a lot about this group of drugs. And unlike, say, spironolactone and eplerenone, this group of drugs cause relatively less of hyperkalemia. But still remember, even in the trials that we have got right now, there's still a 3 times greater risk of hyperkalemia with this group of drug, which is being used. But remember that this has been used in 2 major trials, the Figaro trial and the Fidelity trial. And whatever we are talking about thereafter and what Dr. Bakris talked about is essentially data from the Figaro trial. So if I actually have to put it in 2 or 3 sentences about the 2 trials, it's essentially the same thing, looking at the drug, looking at the same almost group of people, but looking at 2 different endpoints. So the Figaro is a study which has been conducted in individuals with relatively bad kidneys, with either compromised EGFR or albuminuria or both, plus minus retinopathy, and the primary outcome is cardiovascular outcome. And the secondary outcome is the renal outcomes. And whereas the Fidelity trial, it's just the other way around, where you're looking at primarily at the renal outcomes and the cardiovascular outcomes, and the others are more or less the secondary outcomes. And there's another paper which got published thereafter, that's the Fidelity Analysis, which puts these 2 trials together. And essentially the bottom line there is about renal protection, and it's about prevention of cardiovascular events. So if you look at the Fidelity Analysis, essentially it tells us that this group of drug is good in preventing progression of kidney disease and in prevention or reduction of our classical 3-point MACE plus heart failure. Now, thereafter, earlier in November of this year at the American meeting, another analysis of the Figaro trial was actually made. And that is exactly what Dr. Bakris presented at the IDF. So essentially what they now tried to look at this analysis was, you have these group of people with relatively bad kidneys and not necessarily baseline heart failure. And this analysis is all about looking at what happens to heart failure events if you're using a mineralocorticoid antagonist like finerenone. So if I kind of summarize, in this entire analysis that he presented, the new onset hospitalization due to heart failure with finerenone was reduced to 1.9% as compared to 2.8% in the placebo group. The CV death or hospitalization due to heart failure was reduced by almost 18 to 20%. The hospitalization due to heart failure, the first admission, or heart failure related death was reduced by about 29%. So overall, if you look at this group of drug, reduced heart failure events by almost 30%. So here you have a drug which not only improves renal outcomes, but improves heart failure related events. So we already had certain drugs for management of heart failure. We had spironolactone, we had eplerenone. Now to that, he's added this newer drug, finerenone, for prevention of heart failure related events, whether it's new onset heart failure, whether it's prevention of the first hospitalization due to heart failure, whether it is due to recurrence of heart failure, whether it is repeated hospitalization due to heart failure, or whether it's a composite of hospitalization due to heart failure and CV death. So though this was not the primary pre-designed endpoint of the drug, but from the data that's available, it's quite convincing that, after the SGLT2s, we have another group of drugs which are probably going to be used for reduction of heart failure events. And remember that this already is improving kidney outcomes. So if you look at the Figaro DKD study, almost about 60% of patients had microalbuminuria. That tells us two things. Number one, those with microalbuminuria are probably more likely to have heart failure. As an indirect marker of risk of heart failure, you can look at microalbuminuria. And in the study, hospitalization due to heart failure happened in almost 20% of patients. And if you look at the markers, after the use of the drug, we were talking about what are the markers which, or what actually activates the heart failure or the kidney disease. We were talking about certain inflammatory markers. We were talking about IL-6. We were talking about TNF-alpha. We were talking about HSCRP. So in this Figaro study, they have shown that with the use of finerenone, these inflammatory markers come down significantly. So on one hand, we've talked about that these are involved in the pathway of inflammation for the pathogenesis of heart failure and the pathogenesis of chronic kidney disease, and that this drug actually improves these markers, indirectly telling us that inflammation must actually be going down. So that would be, kind of in a nutshell, to talk about the relationship between heart failure and chronic kidney disease, what could be the possible mechanisms, and the newer drug that we are talking about, that it could probably be, at least to some extent, improving on these inflammatory pathways and inflammatory markers. And it's exciting times that we have another drug which will, just like, say, SGLT2 inhibitors, will be working on different things. It will probably be preventing heart failure events. It will probably be protecting the kidneys as well. And finally, one last word, I think, I'll leave with this a bit of a teaser. It kind of tells me now that a lot of those deaths in the SGLT2 CVOT trials, which we thought was actually atherosclerotic death prevention, is actually not atherosclerotic death prevention, but they're actually heart failure death prevention, arrhythmia-related death prevention. And therefore, maybe it's time that, you rethink about positioning of SGLT2 inhibitors as well. When the ADA-ESD says anybody with ASCVD, use an SGLT2 inhibitor, I would kind of think of, it prevents CV death, but I'm not very sure that it prevents atherosclerotic cardiovascular death. I think it prevents more of heart failure-related deaths and arrhythmia-related deaths.
Thank you so much, Sujay. I think very well put and exciting molecule. I believe it hits India in less than 12 months. Another interesting fact about the Figaro DKD, that it said proteinuric patients whose EGFR, almost 65% of them were normal. And the ACR was just around, average ACR was around 300. It was not like 1,000 or higher. It was around 300 ACR. So it's those group of patients who we may actually ignore in practice, and that becomes extremely important. I'm getting Dr. Krishna Seshadri and Dr. Shashank Joshi to respond to this one interesting fact which came around with the SGLT2 inhibitors, that especially from the heart failure study, that one, Sujoy spoke about hyperkalemia, and data suggests that hyperkalemia is lower when you use an SGLT2 inhibitor. And also the durability of these MRAs are better when you use an SGLT2 inhibitor. So probably SGLT2 plus MRAs would be the choice of drugs right up there when we treat patients with heart failure. Dr. Krishna and Dr. Joshi, your comments? It's on mute, Dr. Krishna Seshadri, it's on mute.
I think there is also the issue from the efficacy standpoint, and there was a subgroup analysis of the Figaro study that looked at. Remember that in these studies, these are started quite early, and less than 10% of patients had an SGLT2 at baseline, and on top of that, the MRA was added. These people did indeed have lesser amount of hyperkalemia. That is one. The second thing is the benefit of the SGLT2 being already there. The magnitude of benefit of adding the MRA was not the same as being naive of an SGLT2 inhibitor. Irrespective, there was significant amount of benefit. So the question is, based on this limited subgroup, but this is a pre-specified analysis, we do know that one, there is a lower amount of hyperkalemia when the SGLT2 inhibitor is present. The second thing is, there is probably added efficacy. The question has been always, is it going to be, do you need an MRA on top of an SGLT2 inhibitor? The answer seems to be going in the direction of maybe yes. I'll let Shashank come in.
So at the IDF, I spoke actually on heart failure phenotypes and phenotypes for Asia and low-income countries. See, heart failure management has gone through a 360-degree change. And, originally it was acute heart failure, it was reduced ejection fraction. And we have moved the gear to chronic heart failure, the elephant in the room, as well as the preserved ejection fraction. And it is a personalized approach. So actually the European Society of Cardiology has got a wheel now that if the heart rate, it has a quad rate. So if the heart rate is low, if the heart rate is normal, or if the heart rate is high, presence or absence of low blood pressure, normal blood pressure, high blood pressure, presence and absence of atrial fibrillation, presence and absence of CKD. And these are the 4 quadrants in which a personalized approach to heart failure is there. In that, SGLT2 inhibitors are right at the center. But there is always, as Sujay said, a residual risk. And that residual risk is addressed by MRAs. So MRAs have some very strong, compelling data published this year in the Figaro, and the potassium is taken care of well. So I think it will be a combination of 2 or 3 molecules in the heart failure space, preserving, improving quality of life. Remember, heart failure is once sets in with chronicity is worse than a malignancy. And not only quality of life is compromised, but it is a mortality determinant. And because it is a mortality determinant, it has come on the pecking order. And therefore, it is very important to have a hierarchical preference of drugs using the phenotype of the patient. So it depends on the chain where we are getting the patient and what is our decision-making capacity. Am I seeing a patient in front of me who was admitted for a hospitalization for heart failure, who's a diabetic who has come to my clinic with compromised kidneys and compromised heart? My approach will be different. Am I being called in ICU like Rajiv, where you go at Nanavati, or where Dr. Mittal goes at Max, where he's called in to see a patient who is now moving and transitioning from ICU to a ward? And am I going to give a SGLT2 inhibitor there or MRI there? So it is very contextualized and it is very personalized for that given individual, the decision-making tree. So I think we cannot have one size fit all policy in this space. And we have a larger treatment armamentarium. And MRIs have expanded that space. That's all I can say. Finerenone is a molecule which has expanded that space. And it's something which we look up to, that with that data which is compelling, the US FDA now giving an approval for the molecule. India is likely to have the molecule soon. This will be the next kid of the block, which will add to it. But the overarching non-diabetic heart failure indication of SGLT2 inhibitors and the overarching renal preservating properties of SGLT in the non-diabetic space is pretty compelling. So I think if you ask me, the center stage is still occupied by SGLT2 inhibitors. And then, in specific subsets, as Sujay said, we will have a role for MRs. That would be my take on this.
Thank you so much. Dr. Mittal, you want to add something to? Yes, sir.
No, I mean, I think it's all the points have been very neatly brought out. And, I just say how coolly Shashank is saying SGLT2 inhibitors will occupy center stage. 3 years ago, would he have said that? It's like a given that SGLT2 inhibitors are occupying center stage in management of heart failure. These drugs are hardly like a couple of years old in this space. So that's quite remarkable how the speed at which science is moving, and conferences like IDF bring that out even further. I have just 2 points. One is that I do tend to agree with Sujay, and I've spoken to several people who work in this area also, that the whole SGLT2 mechanism and whatever we are seeing now may be much more towards improving rates of heart failure or reducing mortality from heart failure rather than any major atherosclerotic change. We don't know that, but that's what it looks like. And many of these people who conduct these trials, who are considered pioneers in the field and the basic science also, when you talk to them off the record, they all say, I think they're basically heart failure drugs. They're probably doing some little bit to MI and all, but I'm just saying. So we shouldn't labor that point, but it's there, if you like. The other thing is that the practice changing impact of all this, that's the other. Now, what is happening is, as I keep repeating, that diabetes is a blood glucose, or a diagnosis of diabetes is just an index. It opens the gate to a whole variety of chronic ailments, chronic care diseases, not some of which may not be complications. They may just be associations. So when people come to us for diabetes, our job is not just to manage their hyperglycemia. We've always looked at their eyes and their kidneys and their feet, but it's gone way beyond that. We are worried about fatty liver all the time now. We do worried about fibroscans. In older patients, we're worried about their bones and fracture risk. And I think this, of course, we are worried about their heart, but we're never sure about when to investigate asymptomatic patients, etc. But I think what has changed in my practice, this is just my practice, over the last few months, I would say, that I have become much more liberal with ordering just baseline echoes for anybody who complains of any little breathlessness or fatigue, where I would have held back earlier and said, abhi dekhenge, we'll see how it goes. And the other is that the use of markers like NT-proBNP has increased in my practice a lot in the last few months, because as we understand more and more, you find that many of your patients and involvement of cardiologists who's interested in heart failure has also increased. So in terms of clinical practice, these modules will evolve, and we may be going overboard right now, but the fact is that we have to be alert to these also, rather than only ischemic heart disease, or CAD as you call it.
Thank you so much, Dr. Now, yeah, Dr. Shish, go ahead.
No, just wanted to extend what Amrish is saying. It's very interesting that, I never bothered learning about E primes and E by A's and all of that, but now that becomes something that you document. I would never look at the platelets and be very honest. But now, the platelets are looked at, the albumin is looked at, the AST, ALT.
Yes.
It's changed us, hasn't it? And I think that's wonderful in many ways. I was saying the other day, that there was a time we would eyeball it and wing it. Now we become more, writing down the calculations, like writing down the NAFLD scores, the PIP scores. It's going to take a while for everyone to get used to this, but this is a new practice.
So question to you, Dr. Seshadri. Again, one old practice which we threw off was aspirin as primary prevention, and that was debated here. And we all speak about diabetes being CHD risk equivalent, and then there are studies like on anticoagulants like the Compass, which gives us such benefit. And then we talk that we should not be using an aspirin. So tell us, which side are you in? And it was supposed to be a very good debate there.
It was a very good debate, and let me set up the stage that there was a time when we would use aspirin left, right, and center. It was a practice improvement parameter by which you could get reimbursed in terms of a quality improvement thing. That was number of percentage of patients on aspirin. And then, we started learning a lot of stuff because over a period of time, there have been studies that have come. I'm sure all of us here are old enough to remember the antiplatelet trialist collaborators. And then the last large study was the ASCEND study. So Dr. Armitage, who was the principal investigator of the ASCEND study, and Dr. Roca actually had the debate going. What is interesting is that the ADA, if you look at the successive ADA recommendations, and then of course the EAs, the ESC, you will see that little switch off into secondary prevention. and with good reason. The data is very, very interesting. What I'm going to do is I'm just going to sort of reel out a couple of numbers for you. And this is from a very, very large meta-analysis that was just published here. I used this, I'm bringing this up because it also brings out the Asian data. The important thing to remember is when it comes to preventing events, globally, they're very good. For example, CV events and very, very tight confidence intervals and very low I-squared in terms of the events. So you will find that for CV events, it's the odds ratio 0.91, not much, 0.91, but the upper limit of confidence interval was 0.96. And stroke, and especially ischemic stroke. But interestingly, some of the things that we have been thinking that they will help. It does not reduce all-cause mortality. It does not reduce CV mortality. It does not reduce, interestingly, cancer mortality. Something that we've been saying that is very good for colonic cancer and others. All those, when you look at the big meta-analysis globally, no benefit. Interestingly, in the Asian population, even less benefit. For example, if you look at by region, the Europeans seem to benefit and it sort of mirrors the global population. But if you look at in terms of CV events, there is no CV event benefit in Asian populations. Remember, many of these studies are sort of heavily focused on East Asians, which are very different from, probably us. But that's the data we have, that there is also regional variation in terms of this. Now, in a secondary prevention, adding aspirin on top of your statin and other drugs gives you another 47% reduction in CV events. But in Asians and women, that's not true. And in primary prevention, the data is even more less. Third, there is an increase in bleeding events. Now, the ESC over a period of time, remember there was a time when we were saying use it over 50 and then over 60. 50 with complications and 60 for everyone. They moved back because the older you are, the benefit is less, and the older you are, the bleeding is more. Almost a 40 to 70% increase in bleeding, depending on the study you look at. So where does this bring in? In secondary prevention, absolutely yes. Right? In the right population, addition makes a lot of sense. Even there, individualize it based on risk. Don't use it in older people. If their bleeding risk is high, don't use it. But that brings us to the question of primary prevention. Whether diabetes itself is primary prevention is a question that all of us would ask, because most of us have established risk factors, that it is a continuum, that most people already have probably subclinical cardiovascular disease. And this is where my take comes into it. And that goes with the kind of practice that we're evolving into, right? Start using risk scores. If you have a low CAC, if you have a low Q risk 3, if you have one of those low risk scores that do not push your risk of heart disease, your 10-year risk of heart disease high, then stay out of aspirin. But if you're one of those whose CAC is high, your CAC is between 100 and 400, your lipids are also high, and you're not able to bring it down to less than thing. Your risk of bleeding is low. You're not a woman. You're less than 60. Then maybe you can start using aspirin. But here again, an old molecule. I think it's time to start thinking individualizing treatment based on risk, rather than one size fits all. And that's really my take, that it's time to sort of individualizing it, thinking of the risk, thinking of it as a continuum, and it is one. Remember, it is the cheapest cardiovascular reduction agent, risk reduction agent ever done, but it has its problems. Don't use it in everyone, but use it based on the risk. I think that's my take, and I welcome my other colleagues to comment.
I think I believe Sujay is moving out of the chair and all ready to debate, or is it Shashank? I don't know, because it's always it's an interesting debate in itself, that at one point our patients are lost to follow up, at another point our patients come back to us with an event, and then we are scratching our head that will we do right not putting an aspirin, or not putting a statin, or what should have we done in the first place? So it's in a country where there is no people can buy everything OTC. It's quite risky, but at the same time, I don't know. Most of our high risk patients are lost to follow up. So Shashank, your take on this about primary prevention? You're on mute.
This is all based on a philosophy of risk, very high risk and high risk. Now, we as Asian Indians are already at high risk as a ethnic subgroup for heart disease or vascular disease. In the public health space, we have not generated excellent Indian data, though we have some insights from the inter-heart data, which Salim Yusuf published some years back from Canada, with Prashant Joshi from Nagpur and many others, including Nikhil and Dr. Prabhakaran and the PHFI group, Dr. Srinath Reddy. They have done some work in this area. And their data suggests that, the role of antiplatelets, including aspirin, in type 2 diabetes, secondary prevention is clear cut. So I don't see there is any debate in that. In primary prevention also, it depends on what you call as primary prevention. Because if you have a diabetic who has suffered an silent MI or recurrent silent MIs in their diabetic's life for the last 5 or 10 years, we don't even know. We don't have tools to detect it. So we don't know what is that risk. So probably if I look at a urban Asian Indian type 2 diabetic as a high risk or a very high risk individual, then it between 40 and 70 or 40 and 75, it may be a compelling choice to use a aspirin. Outside that age group or age cohort, but again, as I said, this needs prospective, randomized data the way they have generated in the US. Some early data has been generated from the chronic care disease model of PHFI. But again, it's work in progress, and I don't think we can make a recommendation for Indians. But it definitely can have a life-saving value. The role of aspirin above 70-75 has the risk of GI bleeds, strokes, which can be quite fatal at times, or hemorrhagic strokes to be precise. So it's a double-edged sword. We often see, all of us, whether it's Krishna, Dr. Mittal, Sujay, we all see patients who are senior citizens between 80 and 90. And we often see many of these patients on not aspirin, but multiple other strong antiplatelet agents, and sometimes lead with some very serious and deleterious consequences. So it is basically a double-edged sword. So I think the last word on this is not out. Now, the ESD and the ESC in 2019 came out with a recommendation that 75 to 100 milligram of aspirin may be considered for primary prevention in absence of clear contraindications with people with type 2 diabetes with high or very high cardiovascular risk, but not those at moderate risk. And I feel that Indians between the ages of 30 and 70 probably get into that category. They have also said in that guideline that when there is a low dose aspirin use, PPIs may be considered to prevent GI bleeding, because it's one of the most common side effects of that. And you know that there is a draft guidance in space now, which will be available for primary prevention from the US Preventive Services Task Force. And they feel that it's not helpful. So, it's an American view versus European view, and should be avoided in people above 60. And they put that, there is not a reasonable recommendation. Eric Topal, who leads Medscape, and of course, there is never it's always with a pinch of salt when you read all these news items. How much is the pharmaceutical bias of that? And that US Preventive Task Force gave a grade C recommendation for the younger age group, because the net benefit they feel has not been very overwhelming. So I think the reservation yes, for secondary prevention in a non-Indian setup may be appropriate, but in an Indian setup, I don't think is correct. It's economical, it's off patent, it's available. In those people who need it, should get it with a statin, with an aspirin. Clearly, we can save lives. But as I said, we need to do prospective data. We need to do it in a randomized way. We need our agencies like ICMR to go up to the bar of an NIH and generate some excellent multicentric science to prove this point. But there is a case. If you ask me that there is no case, I would not agree with that. There is a case, because we are as Asian Indians, male, smoker. If there are more than 2 cardiovascular risk factors, you are born in India, it itself gets you into a high or very high risk. So I think it's all about risk categorization. Moderate categorization, I think the level of evidence is weaker. Secondary is a no-brainer. So I'm not getting into secondary at all.
Dr. Mittal or Dr. Ghosh, would you like to add to it?
So the only thing I'd say is that, unfortunately, as Shashank pointed out, we don't have a Framingham kind of study here or any sort of shorter or smaller version of that. So our long-term follow-up data, I mean, how do we know that we need to keep LDL cholesterol below 100? Why not below 95? Why not below 110? So we really are following Western data, and sometimes it is important to follow till we have our own data. But the fact is that it can be misleading. The scoring, I know for sure, for hip fracture is very misleading. And similarly, in this, for outcomes, it can be misleading for us. So, to decide who's high risk, and I don't use the scores, unfortunately, in my practice, and this is being viewed by colleagues and physicians. In my practice, I really go by the number of risk factors that I see, and I use family history as a very strong risk factor in that to decide. Smoking, so like that, I add the risk factors. And if I find that other than diabetes, and I use 10 years of diabetes as a significant risk factor, even that is arbitrary. It's not like absolutely proven. And if I find if other than diabetes, there are 2 significant risk factors in that particular patient, then I tend to veer towards prescribing aspirin. And if I find it's just diabetes in a 35-year-old with nothing else, and then maybe I would hesitate to do that. So, and similarly in the elderly, I agree that subdural hemorrhage that we see is not at all uncommon. You're getting up at night, knocking your head against the wall, and then so that's a common story. So we have to be cautious. But unfortunately, there are gray areas, and there are no hard criteria at the moment that we can use. It's more of, there are some clear patients where you would use it, and some where you would not use it. But there are lots in between where we have to go by a personal judgment. That's at least what I do. I don't know what Sujay has to say about that.
I would just make 2 comments. The first thing is about, we deciding on an individual clinician's basis whether we are giving any benefit or whether we are actually causing more harm. Because, if we are actually preventing primary events, you and I as clinicians don't get to know whether we've actually been able to prevent. But whereas, the flip side, when you see someone with a hemorrhage, you get to see that patient. So you don't know whether you're actually benefiting the patient. And with regards to the risk engines, I'm a bit skeptical at this point of time, because, if you look at the UK PDS risk engine, if you look at the QRisk3 risk engines, the data is very old. Diabetes is no longer what it was in UK PDS. We've moved several decades ahead. You didn't have aggressive use of statins. You didn't have aggressive use of ACE inhibitors, ARBs, SGLT2. So we might actually have already reduced the risk of a lot of these patients with what we are already using. Now, we need something probably more recent in terms of data. Of course, like Professor Seshadri mentioned, the coronary calcium scores might be maybe a way forward. But again, ethnicity-based data is also very important. So those are the 2 small remarks that I thought I would make.
Thank you so much.
Absolutely.
Unfortunately, patients in India are such that they may have seen Dr. Mittal in 1995, and the next follow-up would be in 2025 with Dr. Joshi. He may have required an aspirin then, and now, he develops a subdural at 70. That's unfortunate. Dr. Joshi, over to you. The IDF Atlas actually raises a lot of concern. 1 out of every 10 individual has diabetes. 1 out of 2 adults doesn't know he's a diabetic. So you being the chair of South Asia, is it the same? Is it worse among us? Tell us something about the IDF Atlas which came out.
So IDF Atlas has generated a lot of heat. But let us look at what was the broad points. So globally in 2021, adults between 20 and 79, 537 million people have diabetes, 1 in 10. 1 in 18 people have impaired fasting glucose. So 1 in 10 and 1 in 18 are the 2 numbers of diabetes and IGT. 3 in 4 people with diabetes live in low or middle income countries, including India. 1 in 2 adults are undiagnosed. So it's 240 million people don't know that they have diabetes.
1 in 6 people live births, or 21 million, are affected with hyperglycemia in pregnancy, which means 80% of mothers with GDM. 9% of the global health expenditure is spent on diabetes, which is, US $966 billion. 1 in 9 adults have IGT. 1.2 million children and adolescents below 20 years have type 1 diabetes. So this is the big point in this atlas, that there is a clear explosion happening, including India, of type 1 diabetes. And the 4 million deaths which were attributed due to diabetes has moved up to 6.7 million. And I don't know whether COVID has accentuated that. There is clearly, the IDF estimates show that 1.67 million more adults have impaired glucose tolerance. There is extra $200 billion which were spent on diabetes in the last 2 years. More than 700,000 pregnancies were affected with high glucose. More than 1.8 million adults who are diagnosed with undiagnosed diabetes. So clearly that is there, and extra 2.5 million deaths were caused by diabetes. So that extra 2.5 million deaths distress us, despite of so many advances in diabetes. This is the 10th edition of the atlas. The 9th was in 2019. And clearly, if you see, where is the diabetes exploding? So if you see that in the North America, it is only a 24% increase. In Europe, it's only a 13% increase. So clearly you can see a plateau-like phenomenon in Europe and North America, including Caribbean. Then you move into Western Pacific region, including Australasia, it is 27% increase. Then you move to South America, it is a 50% increase. Then you move to Middle East and North Africa, it is a 87% increase. And South Asia is 68% increase. And Africa is where it is exploding at 134%. So clearly we can see as South Asia, we are predicting currently 90 million diabetics in our region, which includes India, Nepal, Sri Lanka, Bangladesh, Maldives, and Mauritius. And it will move to 2030 to 113 million and 152 million in 2045. So that's the big difference, which is seen, 68. And the estimates keep going up. The number of adults with diabetes are going up. The prevalence has gone up. The number of people living with diabetes have gone up. If you look at the top 10 countries, which are the top 10 countries in the world as per the current atlas? The number 1 is again the pecking order is China, followed by India, right up there. Pakistan comes as number 3 now, which displaces US now. US comes as number 4. Indonesia is number 5. Brazil is number 6. Mexico is number 7. Bangladesh is number 8. It's such a small country, Bangladesh. It's number 8 already. Japan and Egypt. So those are the countries where you can see that these are the top countries with diabetes-related health expenditure, which has gone up tremendously. And the undiagnosed diabetes is the biggest challenge now. And if you look at India, almost 1 in 2, 45 to 54% of people don't know they have diabetes. So that's the big difference. And as I told you, the type 1 diabetes has really exploded. And India is no exception in that. The Southeast Asia region is no exception. And so has IGT, so has pregnancy diabetes. And as I said, the deaths in diabetes are the biggest challenge. But there are limitations of the atlas because the definition of diabetes is based on an epidemiological definition. So for purposes of the atlas, they require only one abnormal glucose value compared to a clinical diagnosis, where for an abnormal glucose, 2 tests are required to make a diagnosis. So there's a lot of heterogeneity when you look at studies of diabetes and the analytical hierarchical process. And there are a lot of countries which don't have in-country databases, and diabetes prevalence is estimated by the demographics, economics, and language. So a lot of errors can be crept in. And from the African region, there is a lot of dearth of data. So that's something which we need to recognize. So from our region, clearly we need to keep our focus on, and we know that prevention is the key, diagnosis is the key, and prevention of deaths is the key. And I think that raises an important question that we really have the burden of complications, unfortunately, which we'll end up treating with diabetes. And clearly, in the 2019 transition to 2021, the addition of the 2.5 million deaths has been not something kind about. Late Dr. Sadiq used to always say that every 6 or 7 seconds, one person dies. Diabetes is a pandemic, and COVID is a pandemic. COVID doesn't seem to be getting over at all. But the COVID pandemic has contributed extra 2.5 million deaths, or were these deaths because of delay in the care? See, in the chronic disease models across the world, one important thing comes out in the atlas is that a lot of our people who are reasonably well controlled diabetics have stopped going to their doctors. They have either consulted us virtually and they have not done their diabetes testing, and they have come with very high sugars. And then they attribute the high sugar to vaccine. They attribute the high sugar to, this is the commonest thing. Amrish is smiling, but I had 4 patients in my clinic today. They said, हमने vaccine लिया और हमारी sugar बढ़ गई.
Same thing I heard today, just today.
Absolutely, it's like, and me and Amrish have very similar type of profile of patient which we see. I mean, I was just trying to tell them, look, you didn't look after, when was your last sugar? When was the last A1C? 2008. 18 was the last time they had tested and seen me. Look at the gap. The gap has been almost 3.5 years. They have not just gone for their care. And now the person has developed diabetes. The person has got edema feet. I need to get a cardiac evaluation done. So obviously there has been a lack of access to care. And these are very well-educated, well-trained people. But unfortunately, the health literacy and health consciousness among people at large has been a challenge, I feel. And that's the big challenge which I see coming in. And that has been illustrated in the atlas. So I think the atlas is just an eye-opener. It's basically to sensitize the communities at large and countries at large and regions at large, to sensitize on 3 areas. One is the hidden burden of disease which is already there. Second is to ensure that we diagnose and treat diabetes aggressively so that we can prevent complications. And thirdly, if there are complications, we treat them aggressively. So I think it's all about prevention ultimately. And of course, there are focus areas of type 1 diabetes. Clearly, it's on the rise. We are all seeing, whether it is because of better diagnostic tools, whether it is because of better ability to access, because a lot of type 1 diabetics probably were lost in a death record. And probably we have now ability to diagnose and treat them better. We don't know. So it's maybe after 10 or 12 years, we'll have better answers on that. GDM is clearly on the rise. I mean, and probably again, the growing philosophy in the GDM world is that it's nothing but pregnancy is like a stress test of diabetes during pregnancy, and therefore it's nothing but a type 2 diabetes being diagnosed during pregnancy. Once controlled, goes away, and after 5 or 10 or 15 years, it comes back. So that's the overarching summary. Of course, Atlas is big. It's full text available, free for everybody on the website. It will get revised. It has a lot of controversies around it, but as I said, because they down-regulated the Indian number, so we had a lot of challenges with that for lack of data. But their way of methodology and analysis has its own. As I said, one thing we learned in COVID, that COVID was predictably unpredictable, and mathematical models all went wrong. Every time they had a model, even now, the current model on Omicron, I don't think any modeler has worked. See, biology has nothing to do with mathematics. We became doctors because we didn't like mathematics. And in medicine, 2 + 2 cannot be 4. We follow a normal Gaussian curve, which is that 95% confidence interval. So we can only be right at 95%. 5% will be an error. And therefore, all these mathematical modeling and public health predictions, they are at best like semi-astrology. They don't have hard evidence. They don't have hard evidence. So Atlas has its own limitation. To say that India numbers have come down is a little unfair, because the research output on the public health space has been a little less. Because, and also the general non-COVID publications have not been accepted by journals. They take 6 months to 1 year to publish. So that doesn't mean that we don't have data. And lack of data doesn't mean that we don't have cases. Like, for example, Africa, they are saying is exploding, but without dearth of data. It's all based on anecdotes. So, when you have anecdotal medicine versus evidence-based medicine, public health modeling of mathematics on an unpredictable model, I think it has its own challenges. But I think overall, we are still in the diabetes pandemic. Diabetes pandemic will stay. COVID may come and go. Diabetes pandemic is here to stay. And COVID has only hurt people living with diabetes. It's hurt them big time. And it's really important to understand that many of our diabetics may lose not because of COVID. We will lose because of lack of their ability to recognize that they will die of hidden complications, which they don't recognize, particularly vascular. What case I saw today was attributing it to the vaccine, the sugars going up, was nothing but feasting and fasting in Diwali, because they had not met their whole family for 2 years almost, like it. So they really had a celebratory mode. So that celebratory mode is actually a killer mode. It's like atherogenic diet and diabetogenic diet. That's what needs counseling. And we clearly see that there is a rise in that. That's I'm sure all five of us have seen that. I think Sujay is smiling. I can see a glee in Krishna. Maybe he has something in his mind to add. And Rajiv, you see this every day. So I think it's still not a gloomy picture for diabetes. I wish we can infuse more positivity in diabetic people at large. They recognize that diabetes is equal to heart attack. We are not into that glam quotient. It's the cardiologist. When they go to a cardiologist, they are in the glam category. The nephrologists are in the depression category. When they go to a nephrologist, it's dialysis and depression. When they go to a cardiologist, it's all about glamour. When they come to a poor diabetologist, it's all about numbers, and they think that we are only talking about that. So it's important that we need to give a spin, and we need to sensitize them and tell them that it's an important thing. It's equal to heart attack. Like when you have an angioplasty, there are 20 relatives. When they come to us, there are not 20 relatives. There is a Baba, there is a homeopath. So we are battling with different enemies. A cardiologist doesn't have any of that. He has his stent, he has his cath lab, and he knows what to do. But when Dr. Mittal has to sit in Max, or Sujay has to sit in IJPMR, or Krishna has to sit in Apollo, or Rajiv has to sit in the Covil Center, he has to battle a lot of alternative complementary areas, which are not easy to handle. For a cardiologist, it's much easier terrain, but for a nephrologist, it's a much easier terrain. We have to actually battle and convince a lot of stakeholders. And this stakeholder management also has been brought out in the Atlas. The reason I said it is because it's important to understand health economics. And I think the Atlas has a very nice chapter on health economics and health expenditure. And it's very important to recognize that the cost of diabetes is in its complications and ultimately in death. And remember, a diabetic person lives probably 8 or 10 years less than normal people. And by recognizing them and seeing you regularly, you are actually adding life to their years, number of years for their life. That's so crucial to tell them that it's a life-saving thing. By just seeing a Dr. Mittal, he's a true messiah because he's adding a couple of years. If you're going to live, and if your astrologer told you that you're going to live till 82, you might probably see Dr. Mittal regularly every 3 months at max, might live probably till 85 or 90, and you might be able to see your great-grandchild's celebratory board. So it's important to recognize that. Do you see that? It's important. You're smiling, Rajiv, but it's a very important point that for a person to live longer, he needs to just see his doctor regularly and follow his advice regularly. And we are giving medications which actually can make an impact now. See, we have compelling molecules. We have molecules which not only impact glucose and hypoglycemia and weight gain, but we have molecules which impact kidney and heart disease and impact mortality and long-term outcomes. We have data. I think we are in a very good space, but our communication strategy is always been battered because of Dr. Google, Dr. WhatsApp, our brothers and sisters from our alternative professions who feel that they have a cure and a magic wand for everything. So that's really the challenge. And this is true all over the world, by the way. I think it's not unique to India. In India, it is a little over-amplified, but it's I think across the world, particularly in underprivileged geographies, like Africa, South America, Asia. So I think I've talked too much. I think I'll open the floor. We all have talks at 8. Actually, it's already past 8.
So Sujoy had one last comment, I believe.
I think, the Atlas gives us an insight of what we are going to face and what the problems are. I think people like you, Dr. Joshi, who have in places should actually convince the government in terms of the healthcare policies that we take in tackling a pandemic like diabetes. And, when we are next formulating the next non-communicable disease program, we need to take cognizance of the problems that are there. And secondly, one of the things, even as doctors, when we were students, we were taught that the Scandinavian nations are the capital of type 1 diabetes. India is right now world's #1 nation in terms of type 1 diabetes. So from a public health point of view, there's nothing in the NCD program on type 1 diabetes in India. So these are issues, when we are formulating healthcare policies, I think we need much greater insights. And I think the Atlas would actually help us in formulating public health policies.
Dr. Krishna, you had something to add on, I believe?
Yeah, I'm just, one lesson from the pandemic is that one of the things that we saw is that so many nations did not have access to vaccines, right? And India has been lucky simply because we have this huge that churns out medications that includes insulin. If the diabetic pandemic goes in the way COVID does, and the lessons that we will learn is that the next big thing is going to be a shortage of medicines in countries where this disease is exploding. And that is a worrisome bit of this whole thing. And in many ways, we in India are blessed and lucky to actually have access to low-cost medications that actually take care of patients. I think I sort of wanted to underscore that blessing that we have. We may crib about a lot of things about our country, but I think some things that we are a little more blessed than. Imagine being in an African nation without access to insulin, and the pandemic actually just and diabetes exploding the way it is. Let's count our blessings as we close.
Thank you so much, Dr. Krishna. Dr. Mittal, your last word.
Just a comment on prevalence of all these non-communicable diseases in India, particularly heart disease. And I've reviewed the data recently for some other purpose. And actually, what it seems like that the genetic predisposition theory is very weak. And it's basically risk factor reduction. This is an increase in different risk factors that's leading to an increase in CAD. If you look carefully at whatever Indian data we have, and we have some good stuff in the global health, global disease burden study and others from India. And when you actually look at that, then the increase in coronary events or death rates is actually largely linked to increase in risk factors. So it really comes back to the fact what Shashank was talking about, our role, because our role is basically managing risk factors, like chronic physicians. So I think we need chronic care physicians. So I think we need to emphasize more and more of that and not let people, because when these young actors and all get heart attacks, oh, India mein to heart attack kaise hona hi hai, kya kare wo to Indian hai. So, we have to sort of fight that also. And I'll just end with that. It's already past 8.
Thank you so much, sir. There are a lot of questions here, but I'm not taking any of them, because I believe a lot of our delegates are going to binge watch this, because that's the kind of knowledge that all 4 of you all have provided here. In school also, I used to run away before the break started. But here, I believe that, we could have extended for an hour and still not got bored. Excellent session. Thank you all so much. And I hand it back to the organizers, Pallavi, as well as the IJCP. Thank you so much.
Thank you so much, sir. And at this moment, I would like to take this opportunity to thank our eminent guests, Dr. Amrish Mittal, sir, Dr. Sujoy Ghosh, sir, Dr. Shashank Joshi, sir, and Professor Krishna G. Shadri, sir, and of course, Dr. Rajiv Govil, sir, for such wonderful insights. It won't be wrong in saying that the highlights of this conference from you 5 makes it all the more interesting. And I hope all the doctors in the audience would have enjoyed this scientific feast. We'll keep on bringing such programs in future as well. So for now, we would like to say good night to everyone. And thank you so much, everyone.
Thank you, Pallavi. Thank you, everyone. Good night.
Good night, everybody. Bye.
Bye.
Merry Christmas to everybody.
Merry Christmas.